Many children with autism may be able to many children with autism may be able to say words. They may repeat words. What is repeating words? By 9 months onwards, many children, when they hear some words, they may repeat it. They may learn many words by rote, but only children with the typical social communication development by 12 to 15 months of them start by 12 to 15 months of age start using them purposively. So purposeful usage of kinship words is a language development that should be asked, and any child who is not using purposive kinship words by 15 months of age is a red flag. And as I said, because joint attention is already emerged, the child is very happy to share interests that she has. Beyond 1.5 years of age, if you had seen children with social communication development, you will understand that many children like showmanship. They like to display whatever they learn. They like to display whatever they already know to their mother. They may just scribble and show it to the mother. They may just arrange two blocks and bring the mother and show all those. The child tries to show everything that he knows, that he does to people around and share this enjoyment. And this joint attention helps. Can you see here? The child is pointing to a toy. The child is taking the mother's attention and then pointing to it. Again, this gives a reason to communicate. One of the first reason to communicate that we saw was calling out to people, asking them for help. Second thing is sharing of interest. This is the second reason to communicate. And after 2 years, once the child has developed thus far, after 2 years, child displays better understanding of language. And between 1.5 to 3 years of age, there is a remarkable progress in language. The child learns one word every day. Child learns at that rapid a pace. Child enjoys company of others. And after 2 years of age, child can indicate most of their needs verbally, can share their interest, can share their enjoyment with others. Beyond 2.5 years of age, child starts seeking information. That is the third reason to communicate, which is seeking information. The child looks at the happenings around. Child is curious about what is happening, and the child knows that the caregiver is a source of help, and child starts seeking information from the caregiver. Appa enga? Where is Appa? Where is Amma? When will Amma come back? All those. So many parents of this age will tell you that he's asking too many questions every day that we are not able to answer most of them. That is typical language and social development. So by 2.5, 3 years of age, they start asking a lot of questions. And after 3 years, the fourth reason to communicate comes, that is giving details. The child will say his name, he'll say his favorite food, he'll say his parents' name, and so on and so forth. So as postgraduates, first you have to understand is there are reasons for a child to communicate. What are they? A 1-year-old child starts communicating for his needs. He starts reaching out to people. That's why the first words are kinship words. The second reason to communicate at 1.5 years of age is sharing interest with the people. Whatever he enjoys, he likes to show to other people. And after 2.5 years of age, child seeks information. Child starts asking questions. And beyond 3 years of age, child gives details. That is those are the four reasons to communicate. So whenever you see a child, especially an older child with speech delay with very minimal speech, if you notice that the child has only very few reasons to communicate, that also may indicate a social communication delay. So what is evident from the discussion so far is language and social skills are closely intertwined and one is heavily dependent on the other. First, a child has to look and listen to the people around. Then the child has to make effort to engage the people around in play and in day-to-day interaction. The child has to engage with people. So the first interest is social attention. Second is social engagement. The third thing is understanding what is being spoken. And the last thing to happen is start talking. And what pulls up the child up this pyramid is a good adult-child interaction. And screen devices naturally, by diverting the attention of the child away from the social environment, can restrict the language development and can also hamper the social communication development. So having understood this, next we can go to how do we approach speech delay in the OPD, outpatient practice. So whenever we talk about approaches, we should know what are the four common differential diagnoses that we are trying to look for. The four common etiologies that we encounter in present day environment is autism spectrum disorder, a child with social communication delay due to suboptimal environment, or a child where speech delay is a part of global development delay, or a child with hearing impairment. With increasing use of neonatal hearing screening, all those, there are very few cases of hearing impairment who are being missed beyond the early ages. But still, it is still a differential diagnosis because it's not uniformly practiced. So the four common etiologies are autism spectrum disorder, social communication delay due to suboptimal environment, speech delay as a part of global development delay, and hearing impairment. Now, the essence of today's talk is this. How are you going to differentiate between these four etiology in your day-to-day practice? There are four trigger questions that you can use to simply differentiate between these four causes. So these are the four simple questions that you have to ask for any child with speech delay to identify the underlying etiology. One, is there a language delay? Yes, if there is a language delay, next question is there a delay in other domains as well? The third question is there an indication for hearing loss in the child? If that is there, then next question is, how is the child's pro-social behavior? So these are the four trigger questions. What are they? Is there a language delay? Is there delay in other domains? Is there any indication of hearing loss? And how is the child's pro-social behavior? What are the indications for hearing loss? Some of the clues will be when talking in front of the child, or when person stands and talks in front of the child, or when when somebody interacts with the child in front of them, their interaction would be good. But somebody who's behind or out of sight of the child, out of visual sphere of the child may not be responding to the people around. But one clue is these children may have very good pro-social behaviors, because socialization is not affected by hearing loss, or socialization may not be affected in a child with hearing loss. And these children will try to mime. They'll try to act out and express what they want. For example, a child who is 2 years of age, who is not hearing well, may ask for water using specific gestures. The child may act out and try to make others understand. So non-verbal communication will be very good in children with hearing loss if their intent to communicate is good. These children may have good socialization. So they may want to convey something or the other to people around, and they will develop other strategies to communicate. It's only that because they are not hearing well, their verbal language will be delayed. But the last, in a child with autism, when you answer the last question, pro-social behaviors will be a concern. They may not be reaching out to people often. And even if they reach out, their communication strategies in general are delayed. It is not only that verbal language is delayed, non-verbal strategies are also delayed. Their gestures may be misdirected, or their gestures will be non-directed and non-specific. For example, a 2-year-old child who has social communication difficulty, when he wants water, he'll only pull their parents' hands to what they want, and the parents have to understand what the child is asking for. The child may not be pointing, the child may not be acting out that he wants water. So are we clear this far? So I'll be showing you a simple video. I want you to look into the video. These are two toddlers. One of them has typical social communication and other has atypical. I want you to go through the video and then understand. So what did you observe? Although these toddlers are both of the same age group, they are 12 to 15-month age group toddlers. This video was taken from the YouTube. This was uploaded by the parents. I just taken a screen grab of it. So what does it show? The child who is on the left side of your screen, the child whom I am pointing to, is trying to engage the people around. This child is aware that there is a social milieu around, and he is very happy to interact with the people around. When they called this child by name, he didn't respond, but this child responded to them. He winked at them, he smiled at them. And the moment he found some toy that is interesting, he wanted to show it to others. Look what I found. He was very happy to show it to others. There was that showmanship present in this child. Whereas this child, although he was interested in the toy, he was playing all alone. He was not trying to look at others. His social attention is less. His response to name call is less, and the sharing of interest is less. So this child, if he presents with speech delay, you may have to work up further for autism spectrum disorder, or you may have to screen this child for autism spectrum disorder. Whereas this child seems to be having a typical social communication trajectory. So I now present some case scenarios. I want one of you to just answer and analyze so that we have understood this one. So may I ask one of the hosts to identify any one of the postgraduates to attempt this case scenario? Ma'am, anyone?
So maybe you can just speak out the case scenario. Our attendees usually put their answers in the
Okay.
chat box.
Sure, ma'am, sure. So this is a 2-year-old girl who was brought with concerns of not talking yet. She goes to a balwadi where she enjoys playing with other children, but at times she has anger outbursts, hitting and pulling the hair of other children. She had attained all her milestones in other domains at appropriate ages. Her head circumference was normal. Neurologically, her gait, tone, deep tendon reflexes were normal, and she had no dysmorphic facial features. So this is a child who presents with speech delay. Probably this scenario I will solve for you. How do we approach this child? I said the 4 trigger questions. Is there a language delay? Yes, there is a language delay. 2-year-old child not yet using verbal communication. Is there a development delay in other domains? Apparently, no. The motor development, although seem to be okay. That's what the parents report. Is there any indication for hearing loss? How will you ask the parents? Out of sight, does the child respond to your name call? Does the child respond to ambient sounds? Children with autism, they have poor response to name calls, but ambient sounds, they may respond very well. What do parents say? பக்கத்து ரூம்ல இருக்கிறான் டிவியில் அவனோட ஃபேவரட் அட்வர்டைஸ்மெண்ட் வருதுன்னா I can turn back. He responds to the ad jingles even in the minutest of frequency. He can respond to calling bell. He can respond to other ambient sounds very well. But it is just that when we call by name, they may not respond. That is the response you'll get from children who have atypical social communication. But this parents say there is poor response to name calls, especially when called from out of her sight. But when I'm in front of her, she responds to simple commands if I show the gestures. What does that say? Definitely hearing responses are a concern. Then you ask the next question, how is her pro-social behavior? This child has good eye contact. She tries to get attention. She shares interest by pointing. She enjoys playing with other children, but just that sometimes she gets frustrated when she's not able to communicate and there are some problem behaviors. She's able to wave by. She has a warm smile. She initiates group play and all that. So what does this child need further? This child needs comprehensive hearing assessment. So just by 4 questions, what have we understood? This child needs hearing evaluation further, and there are no difficulties in social communication. Now, I want you to solve this second vignette here. This is a 3-year-old boy, speech delay, not responding to name call, not mingling with other children. Parents report that he can follow certain known commands and say apple, ball, cat, and few rhyme phrases, but is yet to indicate his needs verbally. He only pulls his parents to what he wants. Parents have put him in a play school, but he does not sit in one place and he roams around in the class. He prefers to be alone, does not play along with other kids. Perinatal period uneventful, motor milestones are okay, and systemic examination was okay. So I'll just give you 30 seconds. You can just figure out what are the answers to the 4 trigger questions. Then we'll discuss. So let's go ahead. Is there a language delay in this child? Definitely yes. Is there delay in other domains? No. Is there any indication for hearing loss? What was the answer of the parents? He can turn and respond to ambient sounds, but it is just that he's not responding to name call. In MChat, one item will be, have you ever wondered if your child is deaf? Parents may feel that he's not responding to name call. Is he really hearing well? That may be the parent's concern. But if you observe closely, ambient sound response are good, but social sounds, calling out to name call, all those are not there. That may not be hearing loss, that may be social inattention. Then, how is the child's pro-social behavior? There are obvious concerns. His interaction is only need-based, is using only hand-on-hand communication. He prefers to play alone and not mingling with people although. So this child further needs level 1 and level 2 autism screening. So are we clear about how to analyze using the trigger questions to reach to conclusion whether it is a global delay, or a hearing impairment, or an autism?
Yes, sir, it's very clear, and we also had a lot of responses in our chat box, and
Okay.
everybody flagged the red flags of ASD,
Oh,
sir.
thank you. So going ahead, many parents are dumbfounded when you say that your child has some red flags for autism, especially educated parents, especially doctor parents, when they say that நிறைய பேசுறானே, he's using so many words. Why do you say that he has autism? There you have to, as pediatric postgraduates, you have to remember that communicating communicating concerns to the parent is a very key step. How do you explain social communication delay to parents? One important thing parents have to understand is saying words and using them for communication are totally different. A child with autism may say many rote learned words. If you remember the second case we ignored, the child was using a lot of rhymes chunks. The child may say wheels on the bus rhymes. The child may sing Baba Black Sheep, all those, but he may not be using them for communication. One example I tell parents is if he's out of your sight, suddenly he falls down, he wants your help. Does your child have to call out to you using Amma, Amma, I need help, or Amma, Amma, come here, or should he sing rhymes? What is more effective for him? What is more efficient for him? So using purposive language is important, and that is what is considered as speech development. Whereas saying rote learned word chunks may not be counted as communication. So many children with ASD early on, they may learn rote learned words, but they may find it difficult to call out to people, seek help, or even express their basic needs to people using verbal communication. There lies the difference that you can point out to the parents and say, and observing the child around in your OPD, you can tell them that he has poor intent to communicate. He reaches out to you only when there is some needs. Otherwise, largely he tries to play alone. He's not sharing interest as much as a 1.5 year child should be doing along with us. And you have to tell them that socialization is a key driver for communication. And children with autism may have speech delay because they may not know why to talk. They may not have much reasons to talk. So those are two things that you have to explain to the parents during when you notice red flags. What are all the other clinical features that you may say? You may see there may be peculiar repetitive body movements called stimming and stereotypies, which many of you may be aware of, and they can have sensory abnormalities like a atypical reaction to certain mundane sounds. What seems very mundane to us or what seems very usual to us may feel very unusually disturbing for them. So these are some features that are associated, and they may have a lot of play deficits. If you observe if you observe children play, children with autism play, they may have very less novelty in their play. They may have poor imagination in their play. Their play pattern is characterized by a lot of repetitive behavior. They may line up objects one behind the other. They may try to cling on to certain objects. They may have prolonged visual inspection of objects. For example, they may turn a car around and they may try to keep spinning the wheel rather than play with the car in a more imaginative way. And by 2 years, children who develop typically have a very good emotional recognition in the tone of voice. Please observe this video. So the moment this person utters ouch, what happens? This child's reaction. Can you see this child's reaction? The child gives a very concerned look. What is happening? This child knows that this person is in trouble and probably she's in pain, and you can see the look of concern on the child's face. That is typical emotional recognition. And look at this child's video. The moment this person says ouch, this child is not responding to what is happening there. He does not pay attention to what this person is going through. He does not recognize that the word ouch may have a sense of meaning, a pain in the meaning, all those. Rather, he starts playing with the toy by himself. So children with autism may not have emotional recognition in tone of voice or in the expression that should happen typically. Now I'm going to show you two children who both have presented with speech delay. One of them is a child who has hearing impairment and one of them is having atypical social communication. I want you to point out which among them is whom. Let's call this child as child A and this child as child B. Look at the video of child A. So as you are viewing, you can say which child has good pro-social behaviors and which child has delayed social behaviors. So what did you observe?
Child A has good pro-social behavior.
Very good. So excellent. So the purpose of the talk is done. So what I wanted you to observe is this is a child who presented with speech delay, but this child has a lot of social attention. This child has a very elaborate pretend play. This child is constantly looking at the people around. She has very good social attention. This child follows what other people are trying to say, all those, and she understands gestures. So when the mom is trying to point out that no, don't do it that way, she understands. This child nods. This child acknowledges all those. So this child has very good pro-social behaviors and she's following gestures very well. So what is the likely reason for speech delay in this child? In fact, this was a child with hearing impairment. Look at this child. Although the father was trying to teach him how to play, his play did not have much novelty. See, here he's trying to point. See, this is a teacup. You can try to pour tea from it. You can try to drink from it. He's trying to show it to the child. But what is the child trying to do? He's only trying to stack one above the other. He's not referencing to the people around. He's not trying to involve his father in his play also. So there is delayed pro-social behaviors in this child. So if this child presents with speech delay, carefully you should evaluate for autism. So the atypical features that should prompt us to think of autism is a delayed intent to communicate, not attentive to the people around. When the child is not attentive to people around and when he does not have much things to communicate to people around, his eye contact will be less, his expressions may be delayed. He may have delayed joint attention, social referencing, and naturally the child's play will have less novelty, pretend play will be delayed. They may have associated stereotypy, sensory issue, and speech delay is a natural effect. So henceforth, between 12 to 18 months of age, as a routine in your OPD, you have to spend some time with the child playing with him, especially during well-child visit, to see if the pro-social behaviors are developing well and the communication is progressing. How early can we make a diagnosis of autism? World over, studies have said that a diagnosis can be reliably established between 14 to 18 months of age, and the diagnostic ability for a diagnosis made at 14 months of age is quite stable. But it is a spectrum disorder, and not all children look alike. The symptoms in different deficits may range from mild to severe, and the symptoms change with age. Why do we say change with age? A toddler usually presents a speech delay. Toddler will have poor non-verbal skills. The child may have atypical social interaction like using others' hands as tool. The child, rather than pointing himself with his own hand, he may lead a person to what he wants and point with the other person's hand. That's a common symptom that parents say. He may have very poor sharing of interest. He may also have repetitive motor stereotypies. But some children are very cognitively able, and parents may not have much opportunities to observe the child during the routine. Working parents, especially all those, or a child who's relatively verbal. The child may be talking a lot, but you may be using very limited verbal language for his communication. Some of these children may be missed in the toddler age group, but when they reach a school-going age group, a teacher can identify the red flags very early. So in school-going age group, what are the problems they may have? These children may only be approaching others for his needs. Otherwise, he may be playing largely alone. He may not be interested in others much. The child's voice may be lot robotic. The child may use a very monotonous robotic voice. The child may have immediate and delayed echolalia, and he may use a lot of rote language use, and sometimes it will be heavily accented. The child may mimic the English that he has learned from a cartoon. The child may have very poor imaginative or pretend play, and still the child may have a lot of social communication difficulty, which can be picked up while interacting with the child. And some of these children may have very narrow interests. They may be very obsessed with cars or dinosaurs or specific themes that they don't play or they don't talk beyond that. Now, having understood the typical speech development, having understood how to approach a child with speech delay, let us now go in for screening for autism in a busy office. How should it start? Always screening for autism is not a standalone. Another take-home message I wanted pediatric PGs to take from today is you should all start practicing regular development surveillance. we should tell the parents that definitely development also has to be monitored, and at least 3 dedicated well-child visits should be practiced to pick up developmental problem. The 9-month visit, the 18-month visit, and the 24 to 30-month visit. In that, the 18-month visit is for identifying language delay. What are some simple questions that you can ask? Does he call you Amma and Appa to get your attention, to show something that you need, or does he seek help by calling you? That is the first question. Then, does he look towards you to see if you're also looking along, to check for joint attention? Does he point specifically to what he wants? Does he nod yes or no to simple choice-making question? And by 18 months, the child should identify 5 body parts. So these are 4 simple language-directed questions. If any one of these 4 questions are no, talk to a pediatrician. So such simple milestone checklists you can give to the parents. And if they have red flags that they have identified, they can talk to you during the vaccine visit that they come to you. So parents can be given checklist which they can pre-fill and then visit to your OPD, and you can right away start the conversation from red flags. Remember, acceptance of developmental problems among parents is better when the red flags are identified by parents and they reach out to you for help. So practicing regular developmental surveillance definitely helps. Once you have identified certain red flag, then you ask the 4 trigger questions. If you identify that the child has poor prosocial behavior, then you have to go for level 1 and level 2 autism screening. Level 1 autism screeners are very quick, efficient tools, more sensitive tools. One of the most commonly used tool all over the world is the MChat Revised. MChat Revised is available for free download from the MChat website. There are translations, meaning approved translations of MChat that is available. There's Tamil, there is Hindi, there is Bengali. Every language that is there is available on this website. And how do you score this also is nicely provided. And in MChat, there are 20 questions except for questions 2, 5, and 12. Except for these 3 questions, any response that is a no, you have to give a score of 1. And for items 2, 5, and 12, a response that is yes indicates a autism risk, so you assign a score of 1. I'll show you some example how we score it. This is just for you to understand. And finally, you total the score. Out of the 20 questions, if the child scores any score that is more than 2, the child needs to be administered an MChat follow. If the child scores more than 8, then the child needs to be referred immediately for early intervention. This is the interpretation of MChat. Now, some of you may say that I don't have time for 20 questions in my OPD. In a busy OPD, I cannot sit and administer all the 20 questions to parents. Sometimes parents may feel impatient to fill up all the 20 questions. Is there any solution for that? Yes. Some of the critical items in MChat have been presented and given as MChat Best 7. That is a tool which is validated in India as well. And another free to download tool is the Parents Observation of Social Interaction, or the POSI. POSI has just 7 questions, and out of these 7 questions, there's a Likert scale. They have to answer it among these 5 categories. And any answer that the parent gives that comes in the last 3 columns, you have to give a score of 1. And any score of 3 or more is at risk. This is similar to MChat. MChat Best 7, and POSI. All of it, a score of more than 2 is a concern. It indicates at risk for autism. MChat is not a diagnostic tool. MChat is a screening tool. So when a child scores more than 2 on MChat, you have to diagnose as the child being at risk for autism. And this is MChat Best 7, the critical 7 items of MChat that are chosen, and they are given as MChat Best 7. I have sent some of these as a handout, which we'll be sharing with the attendees of this CME through the WhatsApp group. And there is a simple observation tool that you can use in your clinic, which can be used for quick and effective screening for autism. What is this? This is the 3-item direct observation score, or the TIDOS score. What is TIDOS? There are 3 items that you do. 1, name call response. 2nd, look for joint attention. 3rd is the quality of eye contact. Just the 3 items. When you call the child by name, if you call twice and the child does not respond, then definitely it's a concern. Then you ask the mother to call twice. So your name call response and mother's name call response. If the child does not respond back, definitely it's a concern. Sometimes parents say, hey, inga paru na itara. Hey, look at here, I'll give you this. Hey, look here, I'm going to give you ice cream. All those, they should not use any reinforcers to call. It should only be calling the child by name. That is first thing. If the child does not respond, red flag. Point to the child an object which is at a distance. So you can have an interesting toy at the far end of your clinic and you can say, look there, I'm going to show you something. Is the child looking? Repeat it once more. 2 times you've done, and if he's not responding, then definitely it's a red flag. And how is the child's quality of eye contact? During your interaction, if you feel the child does not have a clear, flexible, appropriate eye contact, it's a red flag. So just by doing these three simple things, if the child scores as a flag, red flag in all these three items, or if the child scores as being at risk in all the three items, it is having a sensitivity of 95% for recognizing autism in the OPD. This is based on a study which was published in Autism Journal. This can be simply used for a quick screening in your OPD. So now let's try to use some of these practically. This is a case vignette. Aravind is a 24-month-old boy, 2-year-old. He comes to the clinic with his mother. Mother is concerned that his speech and interaction are not optimal. Although he's attained sitting, standing, walking at usual pace, he still is not started speaking well. He does not turn towards member of his family when they call name. He does not seem to look to face at anyone who speak to him. He does not seem to be interested in other kids, does not look where we point at. Family has wondered if he's deaf, but he has had a hearing test and they told it was normal. And when you observe the child sitting on mother's lap, he seems to be interested in the fan in the computer. The computer that you have will have a fan, no? He seems to be listening to that fan. He does not respond to mother's voice, does not show any particular reaction when you call him by name, and he does not regard or copy when you wave to him. As the child enters or when you go next to him to examine, when you say bye or wave to him, he's not looking at you. And when you give a toy, after the toy stops playing, he does not share his enjoyment with parents. And when he wants help, he's only shaking it and shouting rather than reaching out to you or to the parent. So this is the case summary. Now let's see how we score it on some screening tools. So the first tool that I've chosen is parent observation of social interaction, or the POSI tool. So based on the response here, does your child bring things to you to show them to you? The mom said no, and we also observed that when the toy was playing, he was not sharing interest. So the mom scores never for this. Is your child interested in playing with other children? Mom scores rarely. When you say a word or wave to your child, does your child try to copy you? Never. We also observed it, and mom also has scored never. Does your child look at you when you call by his or her name? Less than that is rarely. Mother says that it's only very rarely he does that. Does your child look if you point to something across the room? Other scores never. How does your child usually show something that he or she wants? Mother says he pulls me over or puts my hand on it. He grunts or cries or screams. What is typical response? Says a word for that and he gets, or points with his own finger. That is typical response. What is your child's favorite play activity? Lining up toys, watching things go around like fans or wheels. So this is the mother's response. So among all these seven, all the mother, whatever she has scored in the last three columns, will get a score of 1. So in these 7 questions, whereas the mother scored, all the responses are in the last column. Remember, when you score, if the mother has scored 2 items in the last 3 column, or 2 items, one among which is outside the column and one is inside the column, still you give credence to any one item that is within this column. So you give a score of 1 if any one of these points are shaded in this zone. So this child, the score is 7. As I said, any score of 3 or more is at risk for autism. So POSI has identified that this child is being at risk for autism. Now try to do it for MChat. I've shown just a section of MChat because 20 questions are there. So in this section, if you point at something across the room, does your child look at it? This child, the answer was no. Have you wondered if the child might be deaf? The family said yes, but they got the hearing tested and it was okay. We don't have any information on make-believe play, all those things. Does your child point with one finger to show something interesting? Mom shows no. Is your child interested in other children? Mom scores no. Does a child show you things by bringing them to you or holding them up to you just to share? Again, the question here is not to get help, but just to share. Here the mother shows no. Does a child respond when you call by his or her name? No. So based on these responses, how do we score? Anything except question number 2. No, there are some items that you have to reverse score. 2, 5, and 12. If the score is, if the answer is yes, you give 1. So in this, what all you'll do? 1, 7, 8, 9, 10. You know is the answer. So you give 1 and 2, 5. Both those questions, no? 2, 5 and 12. If it is yes, you score 1. So here 2, the mother has scored yes. So what is the total score? 1, 2, 3, 4, 5, 6. The MChat websites itself has a very good scoring pattern. There is a software that you can download where if you enter, it itself will give a score. But here we have manually done it. In the section that the mom has answered, the total score is 6. Similarly, you have to score for all the 20 questions. And if you were to use TIDOS for this child, the 3-item direct observation scale, child does not look at you or the parent or caregiver. When you point at an object, he does not show any interest. And eye contact that you notice is very rare. So how much is the total score? 2, 2, 1. That is total of 5. The score indicates high risk. Only if the score is 0 on all 3, it is low risk. So any other score is at risk for autism. So this child definitely seems to be at risk for autism. Now, another common problem that we nowadays face is parents themselves may not realize what is good eye contact, what is good interaction. There are instances where when we can obviously notice red flags in a child, when we give MChat to score for parents, the scoring is 0. So what do we do when parents don't realize what is good eye contact, what is good interaction, all those? They need certain videos where they can see what is typical and what is atypical and then use it to answer. So these parents will be benefited from video-based screening measures. And one of the simple app that is available, which is free to download, is AS Detect. This AS Detect app was developed by the La Trobe University in Australia. They validated it in studies and now it is available for free to download both on Android and Google Play Store. These have explanatory videos which guide parents to answer the screening question. And this tool can be applied for children in the age group of 11 to 30 months. So even children who are younger than the MChat age group can be when you notice red flags quite early, you can ask the parents to go through the AS Detect app. I don't know if you're able to see this part of the screen here. There are questions if you can see. Based on the child's age group, eye contact, this is the item. Does your child make regular and consistent eye contact with you and other family members across different settings? And there is a video space here. Once you click this, video plays. This is typical response. This is atypical response. It comes. Then parents have to score how their child responds. Once they make all the choices, then finally a score is computed and a report is sent to the parents, which they can share with the caregiver. So an app-based screening tool helps where the parents themselves don't seem to be aware. So we come to the conclusion of today's talk. The take-home messages that I wanted to say is appropriate development of speech and language not only requires hearing, comprehension, but also ability of the child to socially interact with others. And intent to communicate is necessary for a child. A socialization is a key driver for communication. A child has to pay social attention to people around, establish very good eye contact, involve others in her or his play, and then start communicating with them. So when a child presents with speech delay, look at the child's socialization also. And we discussed these 4 trigger questions to find out the cause for speech delay. I know this slide is very crowded. We have again made it as a part of the handout that we are going to do. What is the first question? Is there a language delay? Is there delay in other domains? If there is delay in other domains, directly go to GDD. If there is only language domain specific delay, then ask for pro-social behavior and hearing concerns so that you can further work up. Now, one cause that we did not address is a child who presents with speech delay, but also has a very suboptimal environment. What is that cause? When we discuss the causes, I said, no, the 4 common causes are autism spectrum disorder, social communication delay due to suboptimal environment, global delay, and hearing impairment. There are a subset of children who present in early toddler age group where they have few autism features. They have few red flags for autism, but these children may have a lot of exposure to screen time. They may have had a very suboptimal environment where both parents are working, grandparents take care, not much a conducive environment for the child to develop language, all those. In such cases where you feel that the environment is suboptimal, you can start interventions for the child and follow up the child very closely. Rather than labeling the child upfront, you can say that this child definitely has social communication concern. I can see red flags for autism in this child. I want you to start intervention. Meanwhile, optimize the environment also, and let us follow up the child closely. Every 3 monthly, let us follow up the child to see how the child's behavior and how the child's development picks up with intervention. So that is a subgroup which you can label as social communication delay due to suboptimal environment having red flags for autism. These children also need close monitoring. And many people nowadays label these children as having virtual autism. This terminology is not an approved terminology. It is not commonly used in scientific literature, although using the term virtual autism trivializes the importance of careful follow-up. Parents will think that it is only because of screen time that child developed this thing. If I stop the screen time, everything is going to be okay. But interaction with the child, other speech intervention, other play interaction to improve engagement, all those are not worked upon, thereby resulting in further developmental delay. So through this forum, I'm trying to place a plea that you can label this child as having social communication delay due to suboptimal environment, which could be the right terminology rather than labeling them as virtual autism. The take-home messages 3 is a toddler who presents at 1.5 years of age with speech delay, whom you pick up during routine development surveillance. If the child has poor pro-social behaviors, think of autism. And early recognition of autism is very rewarding because you can start intervention early. Just by asking 4 trigger questions, you can zero in on the diagnosis early. And ASD-specific screening can be easy to do using parent observation of social interaction or MChat, or using the AS detector. Thank you.
Hi, thank you so much. That was a fantastic talk. That is an underestimation of, that was a brilliant talk. Thank you very much, Srinivasa.
And
perfect for April. Perfect.
Because
I think every one of us needs to be, I think obviously we are doing so much, so little to pick up enough autism spectrum. So I can understand the passion with which you're saying that too. So I think there are a few questions in the chat box.
Yes,
I'll just start with that.
Yes.
There is one question that says, if the parents say that there is a family history of delayed speech, should we wait?
No. So most of these children who present with the communication delay at 18 months of age, if the child is not using purposive kinship words, the child should be having at least 5 words by 18 months of age. And by 2 words, the child should be using 2-word combination. So if that has not happened, it is language delay, dot. There is no role for family history, all those that should come in place here. So if the child has a delay, the child has to be intervened early. So rather than wait and watch, start helping the child earlier. What is more important is when a cause is obvious, when there is suboptimal environment which can be improved upon, or when there are delayed pro-social behavior which can be helped upon, rather than saying or rather than blaming it on other etiologies, the child may need a more specific help in those point. So parents definitely have to be told about what is typical ages of development of most milestone. Surprisingly, many MSc nursing student of us who has done a study in our OPD, most parents don't know the normal ages of attainment of language and social milestone especially. So it is imperative for us to talk to them about typical ages of attainment so that they can identify concerns and they can present to the doctor earlier.
So I got one question from my side.
Yes,
the incidence is increasing of autism is increasing dramatically by
yes, ma'am.
Prevalence or better screening, we are able to catch hold of more cases. And what do you think about the usage of mobile, which produces intense usage of mobile by children less than 2 years also? Maybe does it contribute or it exaggerates the existing illness?
Yes, ma'am. So I'll answer the first question, ma'am. Is there an increasing prevalence? Global prevalence rates are definitely increasing, ma'am. What used to be 1 in 200, 1 in 300 many years before, in the last decade has become to 1 in 50, and the most recent AAP CDC prevalence in US is 1 in 36. In India, they say that the reported prevalence is 1 in 100. So definitely the prevalence has increased, but the reasons for increasing prevalence, people say, is more. Now we have used an umbrella term to diagnose autism. Early age of diagnosis of autism, increasing survival of high-risk neonates, all those which makes them prone for many developmental difficulty. Autism is just one amongst them. So almost 90% of this increase in prevalence is accounted for by very logical explanations like a new diagnostic term, better awareness, all those. But there is still an unaccounted for percentage, which we are still not clear what in environment is resulting in this increased prevalence. But largely, the most of the increased prevalence itself is due to better diagnosis, better awareness, and using an umbrella term, the DSM-5 criteria, to label them as autism spectrum disorders, which previously would have been labeled as PDD, NOS, Asperger's syndrome, in using different terminologies. Now we are coining as a common terminology in them. So that has largely increased in the, that has largely resulted in the increase in prevalence. The next question that you asked was about the screen time. We all know that that is the elephant in the room now. So most people know that it has to be talked about, but யாரும் அதை பத்தி வெளிப்படையா பேசுறதுக்கு தயாரா இல்லாத ஒரு விஷயம். The family dynamics itself have changed, and use of screen time has increased in society in general. Definitely that has affected the quality, caregiver, child interaction, all those. It's an easily available tool. So just to keep the child quiet, just to distract the child during meal time, screen time is often being given. So as pediatrician, we have to start addressing this problem upfront. If you ask many of the parents, when did they introduce screen time first, it would always be around the meal time. அந்த குழந்தை சாப்பிட வைக்கிறதுக்காக நான் கொடுக்க வேண்டியதா இருக்குன்றது தான் மெனி பேரண்ட்ஸோட எக்ஸ்பிளனேஷனா இருக்கும். ஸோ when we counsel about nutrition, when we counsel about complementary feeding, all those, at the same time we should start introducing that IAP guidelines, AAP guidelines world over. Any pediatric society guideline that you take, the strict recommendation or the uniform recommendation is until the child reaches 18 to 24 months of age, child should have 0 screen time. That should be emphasized and re-emphasized and spoken to the parents again and again, because we don't know if it contributes to autism directly. Autism, the present understanding is autism is an epigenetic problem. Again, one thing I wanted to tell PGs here is, do not make the parents feel responsible for the child's problem. குழந்தை நிறைய டிவி காமிச்சா எப்படி குழந்தை பேசும் அப்படின்றது நம்ம போகிற போக்குல சொல்ற ஒரு வாக்கியமா இருக்கலாம், பட் இட் ஹிட்ஸ் த மதர் வெரி ஹார்ட். அந்த வடுவுலேருந்து அந்த அம்மா எப்பயுமே மீள மாட்டாங்க. இட் கிவ்ஸ் அ லாட் ஆஃப் கில்ட் டு த மாம். ஸோ நெவர் யூஸ் தட் வேர்ட். நீங்க டிவி காமிச்சதுனால தான் இது ஆயிடுச்சு. இட் ஹஸ் நெவர் பீன் ப்ரூவன் டில் டேட். Screen time may divert the child's attention away from the parent, may result in a very suboptimal environment for social communication. It is one of the modifiable environment factor. Definitely when you counsel parents, rather you can say, Ma, we are working towards improving the child's interaction towards you. We want him to look at others more. We want to improve his social attention. So at this point of time, we don't want anything diverting his attention away from you. Why don't you cut down the screen time so that we can work with this aspect? If you say that, they take it in a more positive sense. Screen time is not known as a causation, but screen time has definitely been associated with increased risk of autism. Community-based studies in Japan, most recently done, that was published 1 year before, has shown that in boys, it results in 3 times increased risk of autism as compared to girls. Early childhood screen exposure.
One commonly they ask one question. Most of the parents tell us is they would have already had an MRI. They will tell us MRI is absolutely normal.
Yes,
This is doing all other things normal.
yes,
Then here you blame. Why are you brand? What is the standard answer? We can.
yes,
I mean,
yes,
many types.
I have a very standard answer for this, ma'am. நான் உங்ககிட்ட கேட்கறதுனா, if you want to buy a car, would you look at the picture and buy it, இல்ல ஓட்டி பார்த்து வாங்குவீங்களா? That's what I ask, ma'am. ஏன்னா தோற்றத்துல வச்சு மட்டும் அது எப்படி செயல்படுதுன்றது நம்மளால நிர்ணயிக்க முடியாது. How something functions cannot be understood just by the appearance of it. So MRI is just a photo of the brain. It's just the physical structure of the brain which is shown on a 2 dimension. Whereas how the brain functions is what when we see the child function in front of us. So many times பிரெயினோட உருவ தோற்றத்துல பிரச்சனை இல்லாம இருக்கலாம், பட் பிரெயினோட செயல்பாடுகள்ல பிரச்சனை இருக்கலாம், which cannot be picked up on much investigation, which only manifests as the child's behavior, which we see.
One more, maybe we'll keep this last. See, for example, the number of years, for example, we have identified early. Number of years it takes, though it depends upon the severity of the disease and all that, it's a spectrum. But the number of years it takes for a mother to bring the child to a normal school.
Yes, ma'am.
Normal.
I wanted to say this one. We should avoid using the term normal, because the word normal carries a lot of emotional burden along with it, ma'am. So how can this child be made more functional? That is the question that we have to ask. We didn't address much about management, all those, ma'am. So whenever we explain autism to the parents, the first thing we have to tell them parents is, how do you focus on the right questions? We are all trained in a medical school, and we are all trained to think in that aspect. Whenever we see a disease, we think of the pathology, what is wrong, pharmacology, can we cure it giving some medicines? That's what we are trained to think. But unfortunately, neurodevelopmental disorders had to be viewed in a biopsychosocial model. The bodily impairments or the disease per se may not be directly cured, but that's not the question that we should be asking. Can this child function more efficiently? Can this child function more effectively in all settings? So the right questions that the parent should ask is, என் குழந்தையால உரையாட முடியுமா? என் குழந்தையால ஸ்கூல் போக முடியுமா? Can my child make friends? Can my child attend school also? So that question, once the parents ask, what we say is, definitely with early intervention, it is more than likely possible that a child may be able to attend school along with other children also. So the sooner we start intervention, the better the child's language potential, the better the child's cognitive ability, the child is likely to make faster gains. So upfront, when the child comes for first visit, we may not be able to prognosticate. So what we tell parents is, we have to see the child over multiple follow-up visits to see the trajectory of gains. So the early gains, once we start therapy, tells a lot about the child's later on progress as well.
Thank you very much. It was a real wonderful session, Raghavan. We'll have sessions with you in future. Thank you so much.
Thank you.
Isha, thank you, Priya, for having coordinated, and Dr. Lakshmi for having coordinated with the session. And Raghavan, for your kind information, we had exhausted our Zoom numbers. We had to go, and it went into a live stream.
Okay.
And in fact, this happened once before only with Sarath.
Okay.
Balaji. You have exceeded even that number now. Yeah, I'm very happy. Thank you very much.
I think that shows the interest in the topic rather than the speaker, ma'am.
Oh,
I would say that only.
No, that's
And why it's both. Don't underestimate yourself. Thank you, Ram. Thank you.
Thanks, ma'am. Okay, thank you, everyone. We will. Dr. Srinivas, you want to share a document?
Yes, ma'am. I have already sent it to Dr. Lakshmi and Dr. Priya.
Okay, so do you know if, okay, we can try to, we'll send it among our groups.
Sure.
Okay, thank you very much. We will do that.
Good night.
Bye. Good night. Thank you so much.